And I'm really pleased to welcome the final speaker of today before we do the awards, Professor Matt Westmore, and he's Chief Executive of the Health Research Authority. And he's going to tell us all about, as I said previously, what's been going on in the HRA, what's going to be going on in the future, and, you know, real opportunity now to ask lots of questions, plenty of time for questions at the end. And so we can grill him on what's about to happen next in HRA. So welcome, Matt. Thank you very much for joining us today, and over to you.
Thank you, Nikki, and to everyone else, diolch. Hello. The Health Research Authority and Health and Care Research Wales work closely together to deliver a consistent, proportionate and fast approval system across both nations. Now, that was true pre-COVID, of course, but never was this collaborative and coordinated approach so crucial as during our collective response to the pandemic. A collective response that means that never have so many people worldwide depended so much on what we do. Never has research that we have supported been so important, and never has what we do been so well understood and appreciated by our families, our friends and the general public. But blimey though, what a year, because never had we also had to work so hard. And I hope my respect and admiration for what you have done, what you continue to do, will shine through. But I also do want to talk about what next. Where do we go from here? So I'll talk about what we have done together, what we've learned in that process, what are the challenges that now face us as we move through recovery and beyond. I'll begin though by saying that I only joined the HRA just 2 months ago, to the day actually. Previously worked for 12.5 years in and around the NIHR, and I was going to say this is the first time I've been allowed out, so to speak, unsupervised, and please forgive me if I'm a bit sketchy about the details, but that's not actually the case. I'm joined by colleague Matt Harris, who many of you will know, having worked both for Health and Care Research Wales and the Health Research Authority, and as the very personification, the embodiment, the human metaphor for cross Wales and England working. He's here to keep an eye on me. He's here to answer any tricky or detailed questions you might have later. So seriously, thanks, Matt, for joining me. Now, it would have been very easy for Matt to have prepared some materials for me to present to you. To be honest, it probably would have been better had I asked Matt to give you the presentation. His Welsh is no doubt better than mine, at least. But rather than talk at you from behind PowerPoint slides, we wanted to speak with you and discuss with you what we are proud of together, but what we all still want to achieve. And so I'm going to set out some initial thoughts, but leave plenty of time for us to have a chat later. That will help me learn more about our work together as I join the team, but also I hope allow all of us to focus on how do we build on the already really strong and effective partnership between HRA and Health and Care Research Wales, between both organisations and between our delivery communities. And so throughout my talk, please think about areas to discuss, questions you might have, comments you might want to make, and drop them in the chat. I think you might need to refresh your chat to do that, but please do that. I want to start though with a bit of personal context to the last couple of months. I have, of course, joined a virtual organisation, and whilst I'm assured we have some nice offices and a team with bottom halves, not just top halves, I've of course seen neither. But actually, that's not what I want to talk about. 2 weeks before I started at the HRA, my mum had a severe stroke and heart attack. It was her second stroke. The first was 6 years ago, and that had already left her pretty severely disabled. And while she lived independently, I was a primary carer. Now, of course, it was difficult not just starting a new job virtually and with mum in hospital, so desperately ill, not being able to see her or speak to her. But I don't want to talk about that either. What I want to talk about is her experience of research during her treatment. And it's been a source of immense pride and comfort to know how important research has been to mum's care. But at no point was she asked if she wanted to take part in any research herself. Not once. Research has never been mentioned. And I was thinking about why that might be. And of course, I think there's three different reasons. Firstly, there's no research to be done. There are no outstanding questions about acute long-term stroke treatment, or questions about effective speech therapy or reablement or long-term physio-occupational therapy. We just know all the answers already. Perhaps. Or perhaps there are important research questions, but it hasn't been possible to recruit to any non-COVID research projects over the last couple of months, so there were just no stroke studies up and running in her area. Or perhaps research isn't fully embedded in clinical care. It isn't automatic that all patients are ubiquitously given the opportunity to get involved in research, that care teams aren't ubiquitously having the opportunity to learn from their uncertainty in and through their care. My hunch, of course, is that there's no truth in the first and plenty of truth in the second and third, and that's what I want to talk about. How do we recover from the fact that we had to stop all other kinds of research? And how do we carry on our shared goal of truly embedding research in clinical care? Now, there's a lot of talk, of course, about what we can learn from the past year, the remarkable job you have all done in getting COVID-related research up and running, working at incredible speed, delivering results that are saving lives not just in our countries, but across the world. But of course, that was not without its costs, personal costs to you, no doubt, and to the broader research portfolio. And Robin Shattock from Imperial noted that you could drive across a city in minutes when the blue lights are flashing and there is nothing else on the road, but it doesn't mean to say you can do that under normal circumstances. Well, over the last year, the blue lights were flashing, the sirens were wailing, and we closed the roads and we did crowd control and we raced across the city like an American presidential motorcade, or better yet, an emergency response vehicle delivering precious organs or blood to save someone's life. We paused or prevented non-urgent research, and we marshalled COVID research through. We set up special processes, we worked outside our usual remits, and we delivered it all with the latest technology and approaches. And we all worked together day and night, week in, week out, driven by a sense of urgency, a common purpose to get this stuff across town as quickly as possible. Cooperation, prioritisation, proportionate handling and fast tracking worked, but we need to think about how to do that sustainably. And as Robin pointed out, we can't always shut the roads and drive at high speed. But of course, it wasn't all about being in the car going fast either. We had to do this safely. You can't cut corners at any time in our world. You especially can't do it if you're travelling at high speed. So, for example, research transparency and public involvement were priorities for us all before the pandemic. They're priorities during, and they will be priorities going forwards. They're vital to improving the quality of research, building and maintaining public confidence in research, and their willingness to take part. And we've worked together on these issues for many years, through the Make It Public transparency strategy, for example, and many different types of collaborations around public involvement. But they didn't happen automatically during the pandemic. Understandably so, but we had to intervene. And that tells me that there's still work to do to embed them. It's why we worked with Health and Care Research Wales and NIHR and others to ensure that we published information about all approved research within 3 days of approval. And again, public involvement is always important to us. And in the pandemic, it remains important, expected and possible. But like many other things, was more difficult to do. Rates of public involvement in those early COVID studies plummeted to around 20%. Again, understandably so, but we needed to get them back up again to pre-COVID levels. We did that by working in partnership with Health and Care Research Wales, and actually many on the call today, I think, and we established a service to match study teams with the right patient and public groups that were able to provide input at short notice and in a short time frame. And finally, I think the biggest single advantage the UK had, which allowed us to make the biggest single contribution to the global effort, was that we have an integrated health research system embedded in our national health services, and all delivered in the UK-wide way by experts like yourselves across the devolved administrations. That allowed us more than any other nation to work in a coordinated and collaborative way. And so what next? Well, as we move forward, we do so under the almost dizzyingly upbeat desire to recover stronger as a sector by learning from the positives and mitigating the negatives, to build resilience to future health shocks, and to grow both by capitalising on the UK's extraordinary achievements, your extraordinary achievements in relation to research, and in the context of a post-EU transition landscape. Everyone wants to build back better, But how do we do that? How do we do that in a sustainable and prioritised way? How do we do that and maintain our focus on promoting and protecting the interests of patients and participants? Start thinking about those sorts of questions and pop them in the chat for later. For now, though, well, glibly, we must continue to do that together, of course. And that is happening. It's happening at the policy level, at the strategy level, at the process and at the study level. You heard yesterday from Keris, for example, about the UK's ambitious strategy for the future of clinical research that I think sums up some of the areas that we can focus on. Clinical research should be embedded in the NHS. It should be patient-centred, easily accessible to everyone across the UK and delivered by a sustainable and supported research workforce. It says that research and research systems should be streamlined, efficient, innovative and enabled by data and digital tools. More practically, perhaps, I know that you are working exceptionally hard to get the pre-COVID and new non-COVID portfolios back up and running and at full speed. That's essential for patients and it's important for UK PLC, of course. We are necessarily delaying vital treatments during research today and the results necessary to improve wider patient care for tomorrow. It's necessary, but we must remember that research delayed means benefits denied. Commercial sponsors are starting to seek increasing certainty about when research delivery and the care services on which they rely will be able to restart, especially for global studies. Non-commercial funders are facing similar challenges and increased costs and studies are delayed and amended. But thanks to your efforts, 76% of the NIHR portfolio of studies are back up and running in some form. But of course, there is much more still to do. How do we ensure research is fully embedded in clinical care? How do we make sure it's automatic so that all patients, like my mum, are given the opportunity to get involved in research and care teams, like hers, those teams have the opportunity to learn from uncertainty in and through their care? Again, pop some ideas in the chat for later. For me, though, in a word, I think we need to simplify things. That's not to say make things easy, but make them simple. Thinking back to what we learned from COVID again, the beauty of the recovery trial, for example, was not because it was easy. You'll know more than me. It was a fiendishly difficult study to deliver, but the team in the research sector had already done all the difficult wiring in the background that could make the complicated look simple. To make it simple for you to deliver the study, for clinical colleagues to recruit a patient, noting that everyone is probably operating under the most tremendous pressure of their entire careers. And for patients so sick they would not have been able to read, let alone sign multiple times, a 20, 30, 40 page long patient information sheet in order to participate. I think we need to simplify our message to patients, the general public and the life sciences sector so that more can understand the UK research landscape, what we have to offer and how to work with us. Simplify the end-to-end research system by working in collaborative and aligned ways so that it is simpler to get studies approved, to get them set up and delivered, to work and working across multiple parts of the system and multiple countries. And finally, we need to simplify our own processes, whether that be the REC review within the HRA or site set up within your organisations. And to also simplify ourselves, making it easier for patients, the public and other volunteers to be involved and simpler for us as the workforce to be the best we can be. Now, I don't present any of that as some kind of enlightened, insightful new view from the new boy in the organisation. It is, of course, old hat. It's precisely what you have been doing, what the Health Research Authority and Health and Care Research Wales and all the devolved administrations have been working on together for many years. So, for example, the way we've been aligning approvals processes across England and Wales have simplified the approach for sponsors and researchers working on cross-border studies, made it simpler for you to get studies going, only having to focus on local feasibility questions and supported by a consistent UK-wide approach, such as the implementation of local information plans. Or, for example, the use of pharmacy and radiation technical assurances, removing financial negotiations for industry studies through being upfront about prices and speeding up single and multi-centre contracting through the use of model contracts and agreements. This reduces duplication burden, ultimately making it easier for more studies and more sites to be opened up. And so patients and clinical staff can be involved in research anywhere in the country. Patients like my mum. And so just to finish, you might wonder how she is. Well, there's a long rehab journey ahead, but she's home and she's improving, which is fantastic. And it's also not too dramatic to say that had it not been for the work we do in the health research system, she almost certainly would not be alive today. And I now look forward to the day she's invited to take part in research around her reablement and long-term care. Diolch.
Thank you so much, Matt, and to welcome as well Matthew Harris, which many people, as you say, will recognise. He can't stay away. We've got him back only for 10 minutes, though, I'm afraid to say. So anyway, welcome Matthew as well, and thanks to Matt for a really informative talk. So a question from Mandy Edwards. Now, we've had the vaccine registry, the UK registry of people who've volunteered who've expressed an interest that they wish to be contacted about research. And we've had lots of discussions at a UK level about opt-in, opt-out. And so I wonder if you can say a bit more about your reflections on how that's potentially moved, about the public expectations of being contacted about research. You know, will we really need a registry for the future, or will we be able to access people even outside of being their GP or their consultant or nurse?
Yeah, Matt, I don't know if you've got anything to say about that, but I can pick it up in the first instance. You know, how this plays out, who knows? But one of the really interesting pieces of work in this area, which is being led by NHS Digital. I don't know for sure. I think that it might just apply to England only, but I think the concepts are more broad in the sense that the DigiTrials initiative, and what they're trying to do is to create a safe and trusted environment where we can use what we know around from patients' clinical records appropriately, the right people looking at those records in trusted research environments, in trusted clinical environments, in order to recruit into future trials, not necessarily COVID related, but all trials. And I think is a really exciting and it's going to be a really kind of positive and powerful step forward. But it's also going to be difficult. There's going to be some difficult steps to take. And if we do it, you know, if we do it right, then I think patients and the general public will say, well, of course, you know, of course we're happy for you to do that. If we do it wrong, they'll say, absolutely not. What on earth are you doing, rummaging around in my records? So I think it's something that will be accepted by the general public, but only if we bring them along with us. And it's that.
Do you think that's changed with COVID? Do you think that attitude,
yes.
Public attitude?
Yeah, I think so, and it goes to my point about never before has research been so well understood and so well appreciated by the general public. Now that gives us an opportunity, but also a great responsibility, and I certainly don't think we should be complacent about that position. I think we still need to work carefully with patients and patient group to make sure that we maintain that situation. But it is a fantastic opportunity, absolutely. I mean, who'd have thought that, you know, people not down the pub yet, but on the street or whatever will be kind of understanding our numbers and clinical trials and research regulation and things like that, and being really positive about those things and really understanding the difference that what we do makes. So yeah, great opportunity, but also we absolutely shouldn't take that for granted. We need to carry on the work that you know, particularly in Wales, has been really kind of leading in terms of working with patients and patients groups to make sure that we, you know, at one end co-design things, and at the other at least make sure that we're doing things that the public are comfortable with us doing.
Great, and the right to be asked about research, and it not to be a lottery as to who your clinician is, you know, exactly. Feels really important. I feel really passionate about that. And there's a question from Karen Eason about, you know, this is a big ask for you, but can you make it mandatory that doctors ask their patients if they want to be involved about the condition? But I suppose it's a broader question about how can we ensure that even if the treating clinician isn't going to want to do the research, how can we make sure that question is asked and that they're aware of what research is going on for their patient?
Yeah. I'm going to play my new boy card here and say that it's not something I've kind of really got up to speed on the kind of wider. I'm sure this is a long-running conversation. My gut feeling is that making things mandatory in that way, particularly when you are stepping into a really quite special relationship between a clinician and a patient, is probably not the right way to go. So to make it mandatory, as in, I don't know, there's some rule you're breaking if you don't do it. But to make it normal, to make it expected, to make it easy, absolutely. I mean, and I think the UK has been on a wonderful journey over many years of bringing that about. We've still got a lot of ways to go, but if you compare us to other kind of countries around the world, then we are way ahead of having that kind of truly integrated research system embedded within our health services. And so, I'm positive about it. I think there's still definitely work to go. And it kind of my point about, it should just almost be difficult not to be exposed to the opportunity to do research than it is to be exposed to the opportunity. It's just natural. It should be a natural part of patient care. And in many ways it is in the UK, but in many ways it's not. So I'd probably, not having really thought about it too much, I probably would stop short of making it mandatory, just because I'd be worried about kind of mucking around with that relationship but to make it normal and make it expected, absolutely.
Yeah, and there's a few comments there about, unsurprising, we want research asked about, because we're all researchers and working in research, but that sort of expectation, I suppose, that you will be asked about it and how we increase that as well. There's a few comments of concerns about your mum, but I think you provide, so you can pass on our wishes from Wales to her. A question from Reshma about, which is probably an unfair question to ask you, seeing as you're fairly new in post, but maybe for Matthew as well. What's been the biggest lessons learned about the HRA processes and business during the pandemic that you're hoping to now build on and continue to improve?
Matt, do you want to take that?
Yeah, sure. Things that we've learned, how we can. One of the big learning curves is actually our ability to change quite quickly and take different approaches to how we work. Before, I think it was always been a stumbling block that generally when we wanted to make a change, it had to be a quite a long, drawn out process. So a good example of this, and whilst it was, we had to build on the very goodwill of our ethics members, and our staff were involved in it, but that ability to quickly flick a switch in a way to move from face-to-face meetings to virtual meetings to allow a process to carry on going was something that really hits home to all of us, that actually we can make effective changes without substituting the quality. And I think that was a huge learning curve for us when I was in Health and Care Research Wales when we had it, and then subsequently coming back to the HRA as well. So I think the learning from it is that actually it's given us an opportunity to look at what we've done and actually start thinking outside the box and how things can be done differently. And there's lots of work going on at the moment within the Health Research Authority, especially through the ethics review programme, that's challenging these in a positive way, of actually how we can do things differently, and ultimately then how that enables a better experience for the research and how those applications then flow through.
Yeah, so what's an ethics committee going to feel like in the future then, Matthew?
Ooh, interesting. Hopefully still be a very positive and engaging environment going forward. Obviously the ethics review program is still unpicking this of what it will be, but naturally, there may be a blend more of those virtual meetings and sharing an ethics committee might actually be built up of people from across different regions. The fact that virtual meetings, just as we've all experienced it, we're able to drop into meetings, maybe a bit too frequent at this rate, but how we're able to actually to have the co-opted members across different areas from different regions who can bring different experiences as well. So I said that as the virtual meetings go forward, the type of application that comes into the system might be a little bit different as well. These are all things that we're exploring and unpicking that could make it quite different going forward in a positive way, I might add.
And I suppose that makes me think about what those new trial designs and what's the challenges that brings in terms of the traditional review of individual studies, platform trials, amendments, different arms. What's that impacting on in terms of the review process and ongoing oversight from HRA's perspective?
Yeah, I think it goes broader than that as well. So there's one of the things that I've noticed coming in is the kind of desire to kind of think about the kind of the different types of research that we are already seeing, and you know, we treat them differently and things like that. But I think we can do some more work about thinking about what are the true underlying ethical issues or governance issues that need to apply to this particular type of research, and some of those are different for, say, for a platform trial to a set of individual clinical trials. But actually, it's broader than that. So we're doing some kind of just kicking off some really interesting work looking at data-driven research and the use of kind of advanced analytical techniques and AI and these sorts of things. And you know, I think it all comes back to the same core purposes, our same core mission of what we're trying to achieve when we look at these studies. But actually, what does it mean in the context of some of these new methods or new approaches to research? We need to think about how we achieve that differently. So I think that's one of the other things which might feel a bit different about the not just the RECs, but we also look after the Confidentiality Advisory Group as well, which looks at the access to identifiable patient data, but where it's not been possible to get consent, and we'll you know, these groups will be more proportionate to the ethical issues at hand and more applicable to the heterogeneity of the types of studies that we see, given they are changing over time. And certainly, and I'm not saying in any way that HRA has been one size fits all for many years. It hasn't. But actually, the thing we're trying to fit to is changing all the time as well. So I think that means different people coming in with different expertise, understanding the studies in different ways. Matt,
Yeah.
Also, I suppose to add on top of that, with these type of studies that are coming in, I think when you've highlighted the point of having the right expertise, maybe on the right committees to manage these, but also how we work with other regulators as well.
Yeah,
to actually ensure there's an effective way of how we're setting up, so you know how it links with our combined ways of working with the MHRA and any other body that needs to be involved. And I think that it needs to be thinking of the broader research pathway and actually where we fit in it and how we can influence the others as well who are in that pathway.
Yeah, it's a really good point, because I think that's the, you know, I mentioned it earlier in that, you know, the single biggest advantage we had as a United Kingdom was the fact that we had a relatively joined up system already. It might not feel like that, you know, on the ground sometimes, but compared to, you know, most other nations, it's a much more joined up system. We're doing much more of that work. So the experience, the end user experience, will be not kind of giving all of this information to, say, the funder, then to HRA, then to MHRA, then to, not, you know, whatever it might be. It will be, you know, one seamless experience where we're kind of hiding that wiring again, so that, you know, one application comes in and we're sharing the information amongst ourselves. And I know people have been talking about it for many years, and it's, you know, it's just fiendishly difficult to pull off. It sounds simple, but it's just really difficult. But we're getting there. We are starting to connect the system up across the piece, and the relationship between Health and Care Research Wales and HRA is just a wonderful exemplar of that, I think.
Yeah, and I was just going to finish by acknowledging that, really, Matt. You know, we've developed a very strong relationship, not least by sending Matthew over to you. But you know, we've been working with you and other partners and the other devolved administrations in a really positive way, and collectively trying to make sure that those are gaps that are between different processes and between different organisations are really bridged, and I think we've shown how that's been achieved through the last year, but also before that, and is an amazing foundation on which to build. And so we really thank you for joining us today and giving some time to talk to our community.